commentary is encouraged.
So it's important in discography never to touch the needle tip. So I'm using this gauze sterile sponge to put a bend on the tip without actually touching it. So the needle is removed from the sterile sheath. Carefully, a small 15-degree or so bend is placed on the tip to help guide the needle into the nucleus past the articulating process of the facet joint. And you feel a change in resistance there as the needle enters into through the nucleus, in through the outer annulus fibrosus into the nucleus pulposus. So now we'll move down to L3-4. Give me a couple more degrees of oblique towards you, and then about 5 degrees of caudal tilt. Let's go cranial 10 degrees. Good. Just one more shot. Got pinch coming. Raise the skin wheel. Follow that with sub-Q down into the paraspinal musculature. Local anesthetic help take away any muscle spasm again. Reinforce the earlier comment. Remove the sterile sheath. Don't touch the tip. Put the 15-degree bend on that tip. Hold the needle towards the hub. There wasn't enough bend on the tip the first time. There's a subtle bend, but there is a bend. And without ever touching any part of the needle that will go into the disc, proceed. This tip then helps me to bend and guide the needle, rather the bend helps me guide the tip interdiscally. Change of resistance as the needle passes through the annulus into the nucleus. And we'll start to move, get some cranial tilt for 4-5 and S1 positioning. Pinch tug. There's a wheel. %% Lido to give maximal anesthesia. Skin, deeper sub-Q, the muscular tissues of the needle will traverse. Again, sterile gauze unused, bending the tip approximately 15 to 20 degrees without ever touching this piece of the needle. Only the tip will ever go interdiscal, but to be cautious, hold the needle closer to the hub, advance through your anesthetized track, confirm position in the floor, adjust as necessary, in this case, infromedial. Bend the needle in order to get the tip infromedial, more of a central position as it wraps around the articulating process. Change of resistance. Good, so we'll come back with the tilt on to take the oblique off, so we keep the tilt to 2, 3, 4, 4, 5, and we'll go back and target L5, S1. So we'll take the oblique again, and then we'll max out both oblique and cranial tilt. L5, S1 is undoubtedly the hardest disc to access, typically, given the fact that it's the most degenerated, typically because of, you can see on the floor, right, the high rising iliac crest that can impede access to a little bit less. Like that a little bit. Okay. So we'll max out on the cranial, good, and then we'll have to come back low on the oblique. And typically it's a very small area, kind of triangle, that we actually will use to gain access to the disc around it, yeah. Good, very nice. This, one less oblique. And as we come back with less oblique, we see the iliac crest becoming less of an impedance and less of a hindrance to view. Good. Any more? Bring it forward left. Bring it up more. Nice. So end plates are aligned at L5 over S1. The disc is severely degenerated. I'm going to put the marker here, we'll take a shot. And we'll actually mark over the lateral point, similar to how we did in the others, just lateral to the middle of the disc from cranial to caudal projection, lateral to it at the level of the particular process of the dissection. There we go. So that's as good a shot as we're going to get of a severely degenerated disc's access point for L5S1. Taking into account the end plates are now aligned, the iliac crest. We have navigated with oblique projection to get that out of the entryway, and we're going to start to numb the skin. All right, so sting and a burn. Follow perpendicular to the beam, track of skin to anesthetize rather than coming in straight down. We want to provide anesthesia to the direction the needle is going to travel in. Not always, but often a longer needle is required for access to the L5S1. Just given the trajectory, just going to increase that slightly. Now it's small moves with the needle, rotating the tip as we go in order to ensure that the tip is headed medially towards that articulating process, the lateral edge of which will slide by as it enters into what we're seeing is a severely degenerated L5S1 disc. So small shots, frequent images allow us to remain in control of the needle guiding procedure. Felt a subtle change there. We may be onto something in terms of disc entry. Take another shot there. So what we'll do at this point is keep our tilt, come back to the 0 on the oblique, and take a shot to see what we're doing with this tricky disc. We're making some progress. Let's just see if we can get a little further in there. There we go. So we do like to be as close as we can get to the center part of the disc on the lateral to medial projection. That looks not too shabby. So what we're going to do is rotate over to a lateral projection to center each of the needles into the middle of the discs on AP projection, or I should say on a lateral, using a lateral projection, but from AP angularity to make sure that the needle is advancing in the middle of the disc from posterior to anterior. Good, so finalized positioning. This is a nice shot. Oftentimes it's hard to get all 4 discs on one image, but this is a really nice shot here. You always know you're a pro when you get a view like this. Good job, Jimmy. So get each needle centered in the disc. Let's do a full strength. Let me just hold out the hair here. Also the full strength shot. Good, so we'll start with the upper discs and we can adjust our view if necessary for the L5S1. Patient is allergic to contrast dye. Infused with ANSEF in order to ensure minimize risk of discitis, which is the same reason the protocols for holding the needle tip were taking place. All right, Doug, how are you doing? Good. So for L2-3, we're going to start. This can be done with the manometer and or the addition of infusion tubing. But we're going to start here. I'm going to apply some pressure. Let's go live. Feel any pain, Doug?
Sensations.
So, what would you say discomfort is 0 to 10?
6.
Okay, so the patient reported 6 out of 10 pain. Maximal pressure applied here gets us 1.5 mLs, right 1.5 mLs into discally.
7.
And the usual area of pain or not the usual area of pain?
Little higher.
Okay, so discordant pain, put a D, L2-3, 6 out of 10. We're going to call the nucleogram bilobed. We're going to proceed. So the key is to identify the pain in the exact area where you have it on a daily basis. I'm going to go for L3-4. Give me a pain score.
7.
Same area or a different area?
Little lower.
So we're going to call L3-4, 7 out of 10, discordant. The nucleogram shows a bilobe disc, no evidence of fissure, no leakage of omnipaque contrast with antibiotics. Now we'll proceed to L4-5. Live. Hold it. What do you feel, Doug?
9.
Is that the same area of pain or a different area of pain?
Little lower. And on this side, it actually said hitting a little bit on the left side as well.
Okay, so relative to where your everyday pain is, what percentage overlap does this pain pattern have?
It's a 9.
Okay, does it overlap with your everyday pain 50% more or less?
More.
So it feels 70% like your everyday pain? 70-80% concordant, 9 out of 10. Uh, 2 mLs of contrast, endpoint firm in all of these discs. We see the disc really filling up. Take one more shot at this point. Nice, so we don't see any direct fissures. There is transfer of the material within 2 different lobes of the disc. We'll appreciate more of the views on CT discography taken after this test and can review those to get a better sense of individual cuts and slices through the disc. That was 9 out of 10 concordant. So now we'll proceed to L5S1. Let's move the swag, the C. Do one.
You need a breather.
Let's do one full swing. Okay, good. All right. So we're gonna apply pressure here on L5S1. Go you'll see what figure it is called. So 2 ml, 1.5 ml of this of material injected, endpoint is firm. What do you feel, Doug?
9.
Same pain, everyday pain, or different?
Different.
Where is this? What overlap is there? So describe this pain versus your everyday pain.
Oh, it's a 9. It's cranking.
And in terms of the location, how is it different?
It's a little higher
Okay.
with a like a pressure expansion, if that makes any sense.
And in terms of percentage overlap, what percent of this pain overlaps with your everyday pain?
20%.
Okay, so that's discordant, 9 out of 10. Endpoint was firm, 1.5 let's say 1.8 mLs. We'll get.
It's like expanded with a
Sure.
release.
No, of course it is, because that medication's spreading
Yeah.
within the disc, putting pressure in both directions. Let's take another shot of all 4. There we go. So you can see how really degenerated L5S1 is. That's good. Let's drop it a little bit. Let's see. Good. Take one more. Good, and then just roll it down. We can separate the view out, as is often the case. 3 plus 1. One more shot here. Good. Now it came. L5S1, 4, 5, and then let's take the tilt off. Let's go back, call it out. Now we're going to take some more images just to appreciate L3, 4, and L4, 5. Let's take another shot here. 3, 4, 4, 5, and then roll down a little bit. You can see each needle is in the middle of the left to right projection of each disc. Yeah, so we've lost the image here simply because we've taken the tilt off. Okay, Doug, I'm going to take those needles out and put some lidocaine in to numb you up. Hopefully get rid of some of this discomfort. Great job.
It's
Becky, let me get another 1 cc syringe and put this.
all right.